and it's obliquely connected to healthcare disparities, although it's really about healthcare disparities for the poor. And it made me feel good to come to a public hospital, and I think that's what the people who were running this residency were looking for, people who wanted to work in public medicine. So made a big difference for me. I think it's important to the patients, and I think that that sense of the value and the need to treat everybody the same is stands strong at Jacobi.
Yeah, I would. That's our legacy. I mean, that's the cornerstone of what we stood for and still stand for. I mean, in terms of the question, I mean, I struggle. I don't know what the answer is. I go back to what Clint Eastwood said. Man's got to know his limitations. So I don't know if where we in emergency medicine fit in that formula, and I don't know how much on a day-to-day basis, how much we can impact and change the socioeconomic factors and the political factors and all the things that go into overcrowding and homelessness and poor education. I always thought that the best that I could do was to make sure that I was as good as I could possibly be, so that no matter who came through the door, whether it was the CEO driving north on 95 back to Greenwich who crashed his car, or the homeless guy who came in with maggots, that didn't really make any difference. They were at the JIT. They came into my ER, and we were going to take care of them. I knew that shift to shift, day to day, that was going to happen. I didn't feel that I was any different than anybody else. That's the way I was trained. I remember a long time ago somebody saying the words money and patient should never be in the same sentence. 35, 40 years later, I try to follow that. So I don't know what the answer is. I don't think we can turn a blind eye to it. I think we need to think about how we can have a greater impact. But, I think at least on the short term, the one thing you can be assured of is if you every day come to work looking to make sure that you take care of everybody the same way, and you treat everybody the same way you'd want to be treated, then I think that's probably one of the greatest things we can do for our communities. Make sure when they show up in a place like Jacobi that it's a safe haven. They're going to get the care they need, and they're going to be treated with respect and dignity. And people are going to go the extra mile. I remember a long, long time ago when I was at Jacobi as a paramedic, there was a guy, Shelley Jacobson, kind of an iconic figure in our specialty, and Shelley Jacobson used to say, "There's nothing that is beneath the level of physician. You are the common final pathway, and whether that means that you have to come up with this incredible life-saving therapy or it's a bedpan, makes no difference. If the patient needs it, you do it, and that's the way things happen. And I don't think I'd like to think that a lot of the folks who came out of Pelham Parkway are practicing medicine the same way. So, can we do more? Should we do more? Absolutely. Do we need more people in places of power and running the organizations that come from places like Jacobi? Absolutely. No questions about it. But in the short term, if everybody does their job every day, then at least we know our patients are getting the care they deserve.
About another question. The way healthcare disparities is working its way into the pandemic is pretty clear. Once you take a look at it, it's a whole lot easier for me to do social isolation in my big house than it is for a family of 7 to be in a single room apartment sharing beds, and you wonder why should that family have a much higher incidence of the virus? It's obvious.
Yeah, I mean, and that hasn't changed. I mean, they put that up in one of the newspapers lately. The other day they showed the zip codes, and the zip codes with the low socioeconomic indicators had some of the higher levels of penetrance of COVID-19. I mean, it's interesting. I mean, how many times do you have to see the same graphic? You could go back to the 70s and see where the heroin epidemic was. You can go back into the 80s and see where HIV was. Well, HIV was a little bit more of an equal opportunity employer, but you can go back in and see the crack cocaine. I mean, you just go in obesity, diabetes, hypertension, stroke. It's the same zip codes every time. It doesn't change. It's predictable and it's reproducible, and it's one of the few unfortunate real steadying factors that you can rely on. It's going to happen every time, every day, and it's sad.
So Beth Patterson asked a question, can you all hear Manhattan cheering for us? I guess it's 7 p.m., so it's the 7 p.m. Manhattan cheer. What other questions do you guys have?
Yes, I can hear them. They're really loud on my block. It's been happening every night at 7 p.m.
That's cool.
It's really cool.
Yeah. You guys can hear them. Can you hear them?
Oh, wow, cool.
So I guess I have another question. So I guess how long did it take before things sort of returned to normal, I guess, while you were working in these previous epidemics? And at what point did you feel like you were back to practicing the way you used to, and how did it shape your practice?
Specifically around like things like HIV.
Yeah, for sure.
Well, Paul mentioned earlier that it was kind of, that he didn't, the analogy between HIV and COVID. You'd never seen anything like this, and I think we haven't seen some of the things, but I remember in Jacobi coming in the morning, and back in the good old days, in the old Jacobi, there was a medical side and a surgical side, I remember coming in a lot of mornings on the medical side, and every booth was filled with a ventilator and a patient who was being ventilated, and as Paul said, had a fatal diagnosis. Keep in mind, back in the early 80s, in the mid 80s, our conversations around end of life and fetal care and palliative care and DNRs was a whole lot less evolved than it is now. But I remember coming in and seeing that every morning, or not every morning, but many mornings, and going home after a shift and, intubating 3, 4, 5 times. That's what I'm seeing over the last 3 or 4 weeks. The difference is, and I don't know that, we converted, but I think the difference is that as crazy as this has been, at least by our analytics group at NYP, we're flat and we're actually going down, and we expect to see a rapid change. And for about the next 6 days, we're going to be flat and probably slow, and then a pretty rapid diminution over the next 7 days. We expect to be back in reasonable shape by the third week in April, based on the number of admissions, the number of discharges, the number of intubations. The difference between then and now is 6 weeks. Back then, I don't know, Paul, how long was it? 6 years? That was our normal. We didn't know any other normal. And
About the AIDS epidemic?
yeah, how long before we were like, I mean, we were getting hammered for how long?
Well, the AIDS epidemic never took over the hospital. We always had a good number of patients. In fact, most of the patients in the ER were there for something else. This is different. This diagnosis has taken over the entire hospital at every hospital in the country. I mean, it's devastating. It's unbelievable, the numbers. So, I mean, to me, that's the big difference. It's hard to compare this with anything we've ever done before. When SARS was there, and we had several patients a day that we had to gown up for and be careful with, etc. That was one thing, but and learning about PPEs and that kind of stuff. This is different, because this is everyone in the whole hospital seems to be virus positive. Your hospital's been converted into a coronavirus hospital. not much else going on, is my understanding. Is that what you're feeling?
Yeah,
Yes.
I think we can all.
Absolutely.
Definitely what we're all feeling.
Yeah, yesterday I had someone with an appendicitis, and it was very exciting to see someone with a regular disease. And surgery took her to the OR in under an hour, which, because they wanted her out of there and they didn't want to be in my ER.
Right. Come in with
Make sure you save
appendicitis.
that MR number.
No, that's exactly what you had said, how you were saying, like, something different than just coronavirus. Like, and we haven't been seeing the traumas. I also had a right upper quadrant pain that turned out to be acute coli, and it was like, oh my gosh, something that's not corona. This is so nice, because every fever gets a swab and like you almost just assume what it's going to be. So when it's not that, you're like, oh, what a nice change of pace this is.
It will return, and my guess is what'll happen is you'll go from all cases being COVID-19 patients to some patients being COVID-19 and most patients being regular ER patients, and then it'll start to feel much more normal again. You'll be much better at protecting yourself. I mean, if anything comes out of this epidemic, that will be a piece of it. Everyone will be much more savvy about protective gowns and goggles and masks and all the rest of it. But other than that, I have a feeling that you'll be back to near normal in the not too distant future.
Well, I have
So,
a question.
Paul and
Like,
Wally-
I guess. Sorry.
Yeah, go ahead, Tiffany.
In that same vein, so there's been some positive changes that I've noticed. So, we've mobilized entire units of the hospital. There's, 4 or 5 times as many ICU beds as we used to have. So patients are going up faster, and they're not sitting in the ED as long as they would have in the past. And we're having labs come back really quick, and everyone's super responsive and super attentive to the needs of the ED. And my concern is that once everything kind of settles down, like, are we going to go back to the way things were in terms of people kind of like, a lot of the ED boarding? And my question to you is, were there any lasting changes, like administrative, like facility-wide change that you saw that occurred as a result of the AIDS epidemic and the crack epidemic? Like, were there any big changes that people kind of were more attuned to as a result of those events, and like any lasting changes that you noticed?
Not much.
Yeah.
Not much. People still behave the way they behave for some noble reasons and many selfish reasons. I think, the battles over admitting patients continued after, came back and continued after, every major event like this, like 9/11, the SARS mini epidemic. It would be, I would like to be able to tell you that a lot changed, but I'm afraid I don't think it did.